Right, okay, I think we shall get started. So, hello everybody, welcome and thank you for joining us today for what is the 6th in our lunchtime webinar series, Innovation and Impact in Primary Care Research. My name's Helen Bolton and I'm the Communications Officer at the Centre for Academic Primary Care, which I'm going to refer to as CAPSI from now on for short, at the University of Bristol. And I'm delighted that we are joined today by Jean Fader, who is a GP and Professor of Primary Care here at CAPSI, and also Director of UK PRP Vision, the Violence, Health and Society Consortium. Jean was the principal investigator on the original IRIS trial. And also we're joined by Medina Johnson, who is the CEO of IRISi, which is a social enterprise established in 2017 to roll out the IRIS program to GP practices across the country. And Medina was one of the first 2 IRIS advocate educators and holds an honorary contract with the University of Bristol and more, as Medina will explain. So before I hand over to our speakers, I just want to run through a few housekeeping points. We're recording this webinar and we'll share the recording with you, usually within a couple of weeks after the event. During the webinar, you'll be muted and your video will be off. Please pop your questions in the Q&A at any time, and we'll come back to these during the Q&A session towards the end of the webinar. You can upvote questions by sort of liking them, sort of like icon. And just to stress, please do put the questions in Q&A and not in the chat, because that's where we're going to be picking the questions up from. And finally, if you're a friend of Twitter, or X as it's now known, and would like to tweet, please use our hashtag, which is hashtag CAPSI-webinar, C-A-P-C webinar, all one word. Great. Okay, so I am now going to hand over to Jean Fader, who's going to start the proceedings. So thank you, Jean.
And thank you, Helen, for orchestrating this gig. We're going to talk about how, in the case of one research program, we moved out of the academic space, the ivory tower, nicely illustrated actually by the Wills Tower in the University of Bristol, into the world. Because as clinical and health services researchers, even though we enjoy our jobs and we pay the mortgage, what we're really interested in is having an impact on care and on health outside of medical schools. This started the work around responding to domestic abuse in primary care, of which IRIS is our poster child, if you like. In my practice for 21 years, I was a GP in East London, in Hackney, in this salubrious building, a health centre. And my reason for engaging with the problem of domestic violence and abuse really came from patients. At that point, I was a GP and also a cardiovascular and respiratory researcher. And although I was aware of domestic violence and abuse as a problem, as a human rights violation, it hadn't really impacted on me in my work as a GP in an obvious way. Till one evening, it was of course a Friday evening surgery, a patient who I'd known for a long time, for at least 5 or 6 years, was a care worker, came to me complaining about vaginal discharge. And when I took more of a history, she suddenly disclosed that she was being repeatedly raped by her partner, who I also knew. And this shocked me because of the nature of what was happening to her, but also shocked me that this had been completely invisible to me, even though I thought we had a good doctor-patient relationship and I knew quite a lot about her life. But actually, I'd missed the big trauma that was going on in her life. And that was maybe not the only reason, but a very strong driver for Constance, not her real name, and other patients who were just about visible in relation to domestic violence and abuse. And I did not feel able at all to respond appropriately or effectively, or indeed safely. We're going to talk about I'm going to talk about 3 research studies, and Medina is going to talk about what happened next, mostly talk about the IRIS trial, and then also an interrupted time series we did out of that trial, and a further study as well, extending the healthcare response to domestic violence and abuse. When I use the term domestic violence and abuse, I am referring to the UK definition, which is abuse from an adult in your household or in your family. Within that is intimate partner violence, a big part of domestic violence and abuse, but also includes violence, for instance, from a grown-up child, or violence between grown-up siblings within a household. It's a broader definition of intimate partner violence. And domestic violence and abuse includes a whole range of different types of abuse, not just physical abuse. Emotional abuse is in there, sexual abuse, coercive control, which often underpins other forms of abuse. There's economic abuse as well, other ways of controlling an adult in your household. It's an epidemic, pandemic actually, it's a global problem. In the lifetime of women in the UK, 1 in 4 will experience some form of domestic violence and abuse. There's a long delay before there's disclosure and seeking help. Many women never seek any help for the abuse they've experienced. It can end the tip of the iceberg, if you like, of the impact with death, with domestic homicide. Men also can experience domestic violence. It is less prevalent and less, there's less serious violence and there's less sexual violence, but it is also a major impact on men and the male population. And then children are also victims of domestic violence and abuse by being in a home where this happens. They don't have to witness it. Being in a home with domestic violence and abuse impacts children. It's a health issue. It's not just a violation of human rights with economic and social consequences. It actually damages. It's associated with physical ill health, with gynecological problems, and most largely in the long term with mental health problems, particularly depression, anxiety, and PTSD. It also is very costly, not just to individual families where domestic abuse is happening, but across the whole economy. In the mid-90s, last century, there already was a growing societal response, particularly criminal justice and also to some extent in social services. There was a response to domestic violence and abuse. There really wasn't much of a response within health services and within healthcare. And there really wasn't a recognition that this was an issue, despite the health consequences, that health services should engage with. And that was true, by the way, not just in the UK, but globally. There was a lack of recognition of the need for a healthcare response. Primary care is where I live, at least my job. And why start with primary care as a place to look for the health care response? Well, it's because we have the most contact of all parts of the healthcare landscape with the population. And actually, if you look at all the services, public services to the population, there's most contact within primary care. So if you're going to start anywhere in terms of the response from services to domestic violence and abuse, it really has to be general practice. We are nested within a system where we're related to the population, we're related to secondary and tertiary care and social care. What was missing in I would say the early 2000s when we were designing this trial was the link between general practice and domestic violence support. Most of the expertise around supporting survivors comes from the voluntary sector. It doesn't come from the statutory services. And yet that link between general practice, where most of the population has contact, and domestic violence sector was essentially missing. So we developed an intervention, identification referral to improve safety, IRIS, probably still the best acronym that we've come up with over the years of designing trials and trying to find acronyms. The key features were that the host for this was not within primary care general practice. It was actually within a third sector organization, and they would be providing both the training within general practices and the referral pathway. In the pilot itself, we had 48 general practices that were randomized into interventional control practices in two cities, in Bristol and Hackney, East London. And we had an intervention, which I'm going to talk a bit more about, that we designed specifically and tailored to that interface between general practice and the third sector. The goal was to work with the whole team, not just the GPs, and not even just the clinicians, but with the whole team, including reception staff and admin staff. And the training was going to be focused on both of them. This is what the model looks like. Now, when we developed the model, we didn't yet have logic models, believe it or not, in the early 2000s. But in essence, this is a logic model. Now you can't design a trial or try to get any funding without a logic model underpinning it. So the intervention is training and support, referral pathways, prompts in the medical record, an electronic prompt to ask about abuse, a flagging system, and I'll come back in a moment to the advocate, educator, and the practice champion. We provided materials, we provided training around clinical inquiry, about screening, how to validate when a patient disclosed to you, how to document, and how to check for immediate safety. The primary outcome was identification and referral. Pilots among you will notice this is not a distal outcome, it's a proxy outcome, because identification and referral doesn't intrinsically mean that there's benefit to participants or ultimately to patients. How did we have the confidence to argue that to the funders? Well, we were working around systematically reviewed evidence, which finally published as a Cochrane review, that advocacy makes a difference. It makes a difference in terms of safety. It probably makes a difference in terms of mental health outcomes as well, probably. It was enough to convince the funders, and in the end, it was enough to convince the editors of the journal that we published this in. So the identification referral was the primary outcome. What then happened is that the patients who were identified and referred into the third sector organization would get advocacy, emotional and practical support, and ultimately less abuse and improved quality of life and mental health, even though we didn't measure that. We measured identification and referral. Advocate educator is a new role. This was a hybrid role. Someone who could educate clinicians and the admin team, but also receive referrals. A named person known to the practice. This is what's called a warm referral, which has more or less evaporated from the NHS since the early 2000s. And if I refer to a cardiologist now, I don't know their name. We use the warm referral mechanism as a way of trying to really promote the use of the referral. And the referral idea, of course, is very familiar. Those of you who are GPs who work in practices, we do referrals all the time, because a lot of what happens, a proportion of what happens to us in our encounter with patients are beyond our expertise, and we know who to refer to, or at least we know what service to refer to. So we took advantage of that. Clinical inquiry is not screening. I've said that a couple of times because there's big debate about the role of screening for domestic violence and abuse. This is using your clinical intuition, your curiosity, which we need to use a lot in general practice, to ask the question and ask it in a way that's meaningful. And that was hardwired into the training. This was the concept. The concept was a domestic violence aware practice, whole practice effect. And those of you interested in trauma-informed care, and again, this was before we conceptualized some of this stuff, we were looking at it at a structural level as well as an individual clinician or staff. And, this was the result in a cat in a box and whisker trial, box and whisker plot, showing that the intervention really made a difference around identifications and a big relative risk improvement in referrals. Interestingly, you can see in the control arm, there were identifications. If we hadn't done a randomized control trial, we would have given all the credit to the intervention. The absolute difference is not great. Big relative improvement in identification referral, not absolute when we think of the prevalence of domestic violence or abuse. But crucially, we did a cost effectiveness model around this, which we knew we were going to need to try to convince commissioners. And there was actually the point estimate cost savings both for the NHS and societally. We published it in the Lancet. That was nice for all kinds of CV and ref reasons. It also gave a kind of momentum in terms of arguing for the robustness of this evidence. The interesting part for me is what happened beyond the ivory tower, and that did involve focusing on outputs that were not in peer-reviewed journals, no matter how much we like those peer-reviewed journals. And we did that in spades. We really went for other publications, which explained, often with the third sector partners, what the IRIS trial had shown, and the effectiveness of training practices and having a referral pathway. Again, whenever I say that, I think that term, not rocket science. This is, it's pretty basic. The next step then was translation of policy. We did quite a lot of politicking, I guess, in a good sense, to get it cited in various policy documents in the UK and indeed globally. We thought this really was worth shouting about, and the people who were developing this policy guidelines, for instance, were interested in these findings and found them credible. Big question though, hey, this is fine in a trial, but what happens in the real world? We all know about trials that are hopeful in terms of maybe effect size and all the rest of it, but implementing them in the outside world, the effectiveness seems to be less. So we decided we were going to test this with an interrupted time series in sites in northeast London. 200 practices were involved. We had 4 that IRIS was implemented in and 1 that it wasn't, which was acting as kind of a control. And we found, as this shows, a real uptick, literally an uptick there in referrals, similar order of magnitude to the trial, which was actually very pleasing, and I must admit I was a bit surprised by that. So that the top graph is the intervention practices, we can call them that, intervention site, the borough, and the lower one is where IRIS didn't exist, but there was a domestic violence agency in the borough still doing its job, but without a link to general practice. And that we also published and I'm pleased with. And I'm going to end now before I hand over to Medina. General practice, despite me being very biased towards general practice being the right place to do this, there are other services within the healthcare economy landscape that also need to respond to domestic violence and abuse. And we chose sexual health services as the first to really see if we could morph the intervention and make it applicable there. So we adapted the model, we piloted again in East London and Bristol. There was a quantitative study involved in that, and there was also quite an in-depth qualitative study with the staff and with the advocate educators to see how this worked, looking really at the feasibility within a different setting. And we found it was feasible and it was highly acceptable. That was welcomed by frontline staff who felt this was a problem that they weren't able to engage with without that training, without the referral pathway. And again, the kind of effect on identification of referral was consistent with what we found in general practice. Big relative improvement, absolute improvement, more modest. And those were the peer-reviewed publications that came out of it as well. So just to complete my part, I think there's some real generalizable lessons. So for those of you who are researchers thinking about impact, which of course now thankfully we do need to think about. It wasn't there 20 years ago or 30 years ago. It is now. We have to think about impact, particularly for NIHR funding, quite rightly. So thinking about pathways to impact at the beginning, please, rather than in the middle or even as an afterthought. If you can fit in a cost effectiveness analysis into your evaluative study, whether it's a trial or another study, please do. We actually did another cost effectiveness analysis, EEA, with interrupted time series. Get funding for knowledge mobilization. It can't be done on the cheap, and NIHR does get this now, and it's in the template of their grant applications. Go for non-academic outputs. This has become real industry now in a good way. Strategic partnerships with providers, crucial, in particular if it's going to be across the third sector. And then, yeah, you do need luck. There's certainly luck involved in this story. Just a big thank you to the survivors who've been engaged with our research and in our patient and public involvement groups, lived experience groups, and to their families, my incredible colleagues, and needless to say, our wonderful funders. And just a picture of many of them, not all of the incredible colleagues who are responsible for this work. Medina, I think you're on.
Thanks, Jean. Hey, hi everybody. It's lovely to be with you today. As Helen said, I'm Medina Johnson and I am Chief Executive at IRISi. And it's really timely that we meet this week because, as many of you will know, we're at the beginning of the international 16 days of action for the elimination of violence against women and girls. So this is a beautifully timed webinar, and there are many events going on up until the 10th of December. These events start on the 25th of November every year, the day for the elimination of violence against women and girls. So if this does whet your appetite, have a look online. There are lots of other events and meetings that you can attend this week. So what I'm going to do in this second part of the webinar is just move to talking you through how we moved from the research that Jean has outlined into practice, how we've scaled the programme, some of our learning, and then talking you through our experiences of setting up and running a company to sort of mobilise this, and again to sort of try and scale up and replicate. And hopefully, if there are some of you on the meeting today who are in that stage with your research, or at that next stage of thinking, well, how do we get things out into the world? Hopefully, this will provide some useful pointers to you. I'm aware there are lots of different people on the call from lots of different backgrounds, so please do contact us afterwards, whether you're a practitioner, an academic, an early stage researcher. We've sort of been through the whole journey and are still very much going through the journey. So if there are things that we can help you with, please let us know. So to start with, as Jean's outlined, we ran a randomised control trial, which we published, as Jean said, and we had a super funder, the Health Foundation. When we realised very close to the end of the trial, as the results were starting to merge, and we were really overwhelmed by the success in terms of the increase in referrals and identifications, we started talking at some events within the violence against women and girls sector, within the domestic abuse sector, and we were already being contacted by commissioners, colleagues working in safeguarding, working in primary care trusts as they were then. to ask us how could they get this thing, how could they get IRIS, and we were very passionate that we didn't want this great concept and idea to sit on a shelf and somebody to have another wonderful idea 10 years down the line and for it all to be sort of resurrected. So we actually went back to the Health Foundation, who don't generally refund or second fund, and we were hugely delighted and privileged that they did. They agreed to fund some mobilisation time, 2 years, for my part-time salary, our colleague Annie, who was the other of the first two advocate educators' salary, and together with support from the original trial team, we went out to put the research into practice. So we trained areas that were interested in learning with us. We said we were at very early concept, kind of, bear with us. We've got some funding. We're not going to charge you any money to do this with us, but let's us try with you. You try with us and see what happens. And we worked with some amazing partners in the two original trial sites of Bristol and Hackney, based in the frontline services, Nextlink in Bristol, NIA in Hackney, and working with also colleagues in Manchester and Lambeth. They were our first two out of the pilot in the real world, if you like, sites, and they both still run to this day. We then came to the end of that funding, and before we did, thought, well, okay, we've still got something that's going on here that people are interested in. So we were very fortunate that at the time, the Department of Health had an open call for applications to an excellence, innovation and mobilisation fund, which we applied to. On a sliding scale, we realised that if we wanted to make this have legs and be sustainable, we couldn't be living on grants. We had to develop some sort of funding model, some sort of business model that would take us into the future. So the 3 years funding that we applied for and were successful in receiving from the Health Foundation was on a sliding scale of 100% of our costs covered in year 1, 60% in year 2, and 30% in year 3. So we were putting ourselves under pressure, if you like, to go out, develop a business model, develop something that would give our project a longer life, realising very much as we come to step 4 that we actually have a product to sell. And that's something that was quite a jump for those of us working in the front line in the third sector, and also our academic colleagues. We actually have a product. We need to charge for this product because we're providing a service. And actually, if we don't charge, we can't sustain what we're doing, and we can't support more areas to sustain and keep going. So that's what we did. And for sort of 2015-16, we were pretty much self-funding and still based within the host agencies of the Frontline Domestic Abuse Service in Bristol and the Frontline Domestic Abuse Service in Hackney. So when we established the company, when we established IRISi in 2017, we really were standing completely on our own, in terms of everything to do with company setup, starting a bank account, everything around starting a business, which was a very big learning curve. So in 2017, with support from our board at the time, our steering group, which was still made up of some of our original colleagues from academia, some of our research colleagues, and people within the sector. So my director at Nextlink was on our steering group, as was Annie's director at NIA, the Women's Aid organisation there. We felt that this partnership was very much what we needed in order to found and launch our company. So we established in 2017. You can see our very bold vision and mission statements here in front of you. And we are still continuing and developing and pioneering, building a network of partners. And it's lovely to recognise some names of people on the meeting today who are working with us to share our vision and try and create that sustained change in the healthcare service by the specialisms of health and the third sector working together. James outlined the logic model for the IRIS programme, and this is really what we pitch to commissioners and what we hold true to today. So in a nutshell, we're a training and referral programme. We support general practice teams, the whole practice family, as Jean said, not only the clinicians, but the reception administration, anyone who's patient-facing staff, to recognise patients affected by domestic violence and abuse, ask them about it and risk check, provide an understanding, empathic response, offer a referral to the advocate educator, and make a record in the patient medical record of the conversation and the consultation. Even if there hasn't been a disclosure, the mere fact of a clinician or someone in a practice recognising and asking someone affected by domestic violence and abuse, there's something that I'm concerned about. Is there anything happening for you? Is there anything that you want to talk to me about? Tell me about your relationship. Tell me how things are at home. Even if at that point the patient chooses to not disclose or ask for help, by having had that opening, she knows that if she wants to go back at any point in the future, the person asking the question will know what to do and how to support her. And we also collected data on the number of conversations and disclosures that didn't actually lead immediately to a referral, but we know very much that many patients came back subsequently for future consultations, or in fact self-referred. I remember working with many women who'd self-referred. So as Jean said, we know that this increases identifications and referrals, and it works very much in two directions. It upskills the staff and the clinicians and the whole practice teams to better support patients, and it improves quality of life for patients. Jean's talked through some of the impacts that domestic violence and abuse can have on the health of patients and survivors. And as he said, we've worked right from the very start with survivors to help us develop the research, develop the programme that we now run, and we work with survivor panels on every step of the way in the work that we do at IRISi. And these things still hold true today, that survivors tell us that they want from healthcare professionals to feel comfortable and supported to disclose, that there's a safe environment, that they're not going to be judged, they're not going to be told to do something, they're going to be worked and supported through a patient-centred, person-centred, trauma-informed support package. They want to be asked directly. They want an immediate response, even if they choose to not do anything at the point of disclosing. They want to know that if they choose to disclose at some point and take the next step, that there will be the support there. And that continuity of care that Jean also referenced. So this is the journey that we've been on so far, and Jean talked about an uptick. This is one of my favourite slides to present, because we see this really lovely uptick as well in terms of the support that our programmes delivered in partnership with frontline expert violence against women and girls services have been able to facilitate. So this is our data up to March 2022. Our national report for the financial year 22 to 23 is going to be launched in January. We're just signing that off and checking that through at the moment. So these figures will increase, but the data that I can share with you at the moment goes from what Jean was talking to us about, those 48 practices in the IRIS trial, 24 intervention, 24 control. So we went from 24 practices to now almost 1,500 fully trained practices. It's about 20% of all the general practices in England and Wales, which is great. And it's not enough, because there are 80% where the clinicians don't have this package of support, which means that their patients also don't have this package of support. So we really want to shift that and improve and continue to scale. The very large number that you see there at the bottom, over 30,000 patients have been referred since we started scaling up our programme and being a programme that can be commissioned by health, public health, primary care, local authority teams in local areas. We know in many of the areas where these patients are referred, over 80% of them will not have been asked about domestic abuse before, will never have disclosed, will never have thought there is a service that can support them. So for many of these people, the IRIS programme is offering them the earliest possible opportunity to seek support. And we know that it creates greater safety, reduces risk, and we'll come on and look at some of the comments that people have shared about the programme in a moment. So patient voice is crucial. And I've just highlighted a few things here, showing that partnership working really successfully of general practice working with the specialist sector. So someone saying, I'm indebted to my GP for piecing it all together and getting me that help. Someone else I would never have called or seen if it wasn't for my GP referring me to see someone in my surgery. It's like an extension of my GP. And then this last one, which is a lovely summary. I feel my physical and mental health has improved, visiting the GP less, and I feel that my child is safer now. So again, talking back to what Jean said about the whole family being affected when there are issues of domestic violence and abuse. Clinicians are positive too, feeling that it empowers clinicians to act, and then it brings change, a big impact. Excuse me, we've had some blocks and challenges. Sustainability is always the word that is the stumbling block. Sustainable funding, sustainable commissioning, systems that want our programs to be sustainable, but can sometimes not really underpin that in the way that they work. So short-term funding and commissioning cycles are problematic, and support for things that are more than training are challenging as well when we're trying to ask for funding for salary costs and continuing salary costs, so that the advocate educator becomes an embedded member of the general practice. That also can be challenging. I'm sure this won't come as news to many of you. Everybody can think that the work that we do in trials and out there in services is great. Everybody thinks it's great, but nobody wants to pay for it. And I do appreciate that we're talking in a time of austerity, 40% cuts within the NHS. I know things are tight. And I'm also passionate that with very, very limited public funds, we're using them wisely and effectively. We're not doing things on the cheap. We're not doing things that we think might work. Let's do things that we know work. Let's do things that are demonstrated best practice, where we have decades worth of research, data, qualitative and quantitative, and we have robust evaluation and academic rigor. As Jean said, we not only are working in primary care, we're also working in sexual health now. And our ambition as an organisation is to have a suite of programmes that will meet the need for a patient affected by domestic violence and abuse, wherever she is at in her journey, in whatever part of the health sector she is working and being supported as a patient. So IRIS covers primary care. Advise is now working in sexual health. And as you can see there at the bottom of the slide, we started this very recently, just a couple of years ago. We're now running in 4 areas of Greater Manchester, about to start in 2 areas of London, and we've also been running in 2 areas of the Southwest, Bristol and South Gloucestershire, for, I think this is our 2nd year now, and we're nearing 1,000 referrals from those programmes. And this really reinforces again this quote that patients welcome being asked about domestic violence and abuse and sexual violence for advice. Even if they've never been involved in an incident, they appreciate that this is something that is supported by their healthcare professional and would be somewhere that they could seek support should they need to. So I'm just going to spend the last 2 or 3 minutes talking about how we moved from research into practice and the very sort of key things, I think, our key learning. I think consistency of staff from the research into the practice and the setting up of IRISi was really important. We have that institutional memory. We can remember how things were developed, how things were challenging, and how we met those challenges. I think a key thing that I talk quite a lot with people who are looking to move the academic work that they've done into practice. I think it's quite interesting that the leads on this, Annie and I, came from the sector with great support from commercialisation colleagues at Bristol University, Jean as a GP and an academic, and other people who were involved in the trial, the researchers and the trialists. But actually the people who could, because we weren't on an academic trajectory, we were working in the sector, we, I think, had, as well as the passion, and we'd gone out and found the funding for our salaries, we were able to, because we had that funding, give the time to developing the programme. And I think, as I said a moment ago there in the top right, it was this shift from realising we had something that was really great, that really worked, but we couldn't give it away because we couldn't sustain developing the programme and supporting more and more people to access it if we just gave it away, because then we wouldn't be around to do that. We had to market ourselves and we had to market our product. And I think that triangle that I talked about, that triangle of the advocate role, who became the sort of business lead and developer, if you like, the academic and the GP, and then the commercialization team and leads at Bristol University, were very key. And those partnerships still stand. And on our board of directors for IRISi, we still have that triangle plus other areas of expertise. Some of our initial barriers were passion gets you a long way. A conversation, getting in front of the right people, gets you a long way, but we were limited in terms of our business experience and expertise. And if we were on this journey again, or if you're about to start this journey, I would very much recommend talking with others who have gone from concept into practice. How do you set up an organization? What do you need in terms of basic financial procedures, basic HR structures, basic policies? We developed organically, which was great and challenging. And I think we could have saved some time and some effort if we'd worked smarter and not harder. And smarter would have been talking to some people who'd done this before. The paucity of sustainable funding is always the big elephant in the room, and sadly I think it will always continue to be. So we have to become creative and think about new and different ways of raising funds. We're working in health, which is challenging itself, even without, as I said, 40% cuts in the NHS that we've seen this year. We're still coming out of the pandemic. It's a challenging system and a challenging structure in which to work. And we can make it work. And working with passionate, brilliant individuals within the health structure very much supports that. We're starting to see some cheaper, less robust alternatives to IRIS emerging. There are some programs that offer training, and as I said, training is great, and it's only part of the solution. If we train clinicians to become aware, to be clinically curious, but we don't have anywhere where they can refer their patients onto, then we're relying on already very poorly funded, struggling frontline services to pick up the next step. We need to be funding, working as a sort of cohesive system to make sure that everybody is held and everybody is supported in the best way they can be. We've had some great facilitators. So connections, I can't underestimate the value of connections wherever you go, conversations about what you're doing, the credibility of coming from an evidence base of a randomized controlled trial. That academic rigor has served us really, really well and continues to, as do the evaluations that we have done as part of the research work, and also now some of our partners do in the programs that they run out there in practice. I can see that a couple of people have put questions in the Q&A about how do you get into policy and how do you get into legislation and how do you get the issue recognised. And again, I think it's connections, some of it is serendipitous, I have to say, and some of it is hard work. You keep on having the same conversations and banging on doors, and you know the doors open eventually, and then when you get in the room, your passion and credibility and evidence base will work for you. I think in what we're talking about here and what we've been doing at IRISi, and in terms of the violence against women and girls sector, we have a Domestic Abuse Act now, which has come into being since we set up IRISi as a company. So obviously that supports us, and IRIS and the IRIS programme are mentioned in the statutory guidance that sit alongside the Domestic Abuse Act. And that also hand in hand has come because we have an office for the Domestic Abuse Commissioner, and working with her office, getting in front of, putting yourself in front of people at local government level, regional government level and national government level, statutory and policy level, helps to get recognised and helps us to get into policy and practice. We also have a team now at NHS England focusing on domestic abuse and sexual violence, and that work and the work that they do in partnership with the sector is also priceless in making sure that our issue is out there, is getting heard about and is getting recognised. And just to finish, what next? Well, we keep doing what we're doing. We keep constantly reinforcing that we want best practice, evidence-based, robustly evaluated programmes to be commissioned. We want to continue to scale and continue to innovate. So we're looking at developing adapted IRIS programmes for health visiting. We've done some work in dentistry. We're looking at some work around maternal mental health. So we continue to be creative and also creative around our fundraising. And everything that we do, we want to be supporting the early intervention for patients affected by domestic abuse. We want it to reduce risk, and we want it to improve the health and life of women and families and victims who are affected. And Jean, I think you're going to lead us into the final section before we take questions.
Thanks, Medina. I've been trying to answer some of the questions in the Q&A. I may not have answered them to your satisfaction. And I'm just thinking about one around intersectionality. Medina, I wonder if I could pitch that to you, because Lumide has asked, okay, within the program, what's the engagement with intersectionality? And, you know, also what is the reach out to marginalized or maybe, let's say, like migrant communities? How much has that been integrated into the work of IRISi?
Thanks, Jean. Yeah, it's a really great question. We need to do more and better on this. We are trying really hard, and in the last 2 or 3 years, we've really improved what we do around this. We know that whether we're looking at IRIS data for patients referred in through the IRIS programme, or whether we're looking at the sort of throughput of patients in primary care anyway, we know that many communities are just not visible. And what I'm really keen to understand from an IRIS perspective is, what can we do about that? So is there anything in our programmes that is making it difficult for people from any communities or any protected characteristics to access what we're doing? We work in partnership with specialist buying for services. So we've worked with the Asian Women's Resource Centre to run some specialist training on harmful practices. We've done some work very recently with the National Centre for the Centre for Non-Fatal Strangulation. One of our colleagues developed a training module for Black women affected by domestic violence and abuse. We know that maternity care for women from Afro-Caribbean backgrounds is shockingly poor when we compare it to other communities. We've also been reaching out to and are now working with some specialist buying for services. So delivering our programme, we're now working with the agency I just mentioned, Asian Women's Resource Centre in London. We also work with London Black Women's Project, and we also work with Anchal, who are based in Newham and delivering our programme in Redbridge. With Advise, we're very interested in the diversity of patients and population who are coming through. So we're seeing a lot of gay men. We're seeing a lot of people from the broader LGBTQ plus communities, and we work with specialist organisations up in the Greater Manchester area around these communities to make sure that whatever support somebody needs, with whatever additional experiences they have or barriers that they have, because of their protected characteristics, they are appropriately supported. So it's definitely not a one size fits all, and it could be better.
Okay, now we have a flood of really interesting questions, which I'm going to try to quickly prioritize. I'm actually going to start with the last one about clinicians as survivors of domestic abuse, and yes, building on the pressure study. led by Sandy Diensa and Alison Gregory. And there is the next step, which will be led by Sandy in developing a response for that. And there will be a new study, which I'm not gonna in any way publicize now because it's not yet in the public domain. But yes, I think that's crucial work. I mean, we'd have thought that we, as a community of doctors, among the highest, have the highest proportion of survivors of domestic violence and abuse. But yes, so that will happen. There was.
Sorry, Jane, can I chip in on that just before we move on, just really quickly?
Put a link in as well around the pressure study. Yeah, sorry, Medina.
No, that's okay. When I was working as an advocate educator, delivering training in practices and working with healthcare professionals, we would rarely at the end of a session not have, we would always make sure, and we still do, our trainers always make sure that there is time at the end of a session in case anyone does want to come and talk to us about whatever it is. It's rare, sadly, that one of those conversations isn't someone disclosing or asking for some support as a friend, sister, brother, colleague, relative of someone affected by domestic abuse. So I think it's brilliant that this work is happening. And the next stage work that Jean slightly tantalizingly said he can't say very much more about, we're involved with that. IRISi are partnering on that as well. And finally on that, just to say, you know, the NHS is the biggest employer in Europe. Have I got that right? And the majority of the employees on a clinical and professional service basis are women. And this is a gendered issue, so you know it's not surprising, and it's great that this is now happening. Yeah, we're responding now. Thanks, Jean. You're struggling to get off mute.
I am indeed struggling to get off.
Oh, there you go.
I have the Q&A open as a screen, and of course you can do two things at once. I can't do two things at once. Look, there was a very specific question about Devon and Cornwall. What's the service there?
Yeah, I can respond to that.
Yeah,
I can respond to that. Thank you. So Devon is really interesting. IRISi worked with Devon and in Devon for 3 years. And Devon commissioners came to us and said, we like IRIS and we want it to be bigger. We don't want it to be only domestic abuse. We want it to respond to sexual violence as well. So IRISi worked with Devon Rape Crisis, and we amended, edited, developed and produced an IRIS program that does respond to domestic abuse and sexual violence, which we ran for three years, I'm going to say. The local NHS trust decided that they wanted to go broader, and they now run an interpersonal abuse service, interpersonal trauma service, can't quite remember, delivered through Fear Free. We train them, they deliver the IRIS training, and they are also, we understand, wanting to deliver wider modules around men as survivors and children and young people as survivors. And Jean, perhaps you can say something about IRIS Plus shortly. Within Cornwall, my understanding is that the local public health or perhaps community safety team commission a HIDVA, a health IDVA. It's not the IRIS programme. They did run the IRIS programme for a while in Cornwall, funded through the wonderful Cornwall Women's Centre based in Bodmin. And unfortunately, we were not able to get any traction or any funding from the health commissioners at the time. So IRIS isn't running in Cornwall. There is good work going on in Cornwall. Around the older people's service, I know that Solace Women's Aid run a project called the Silver Project, which you can Google, and that is specifically aimed at women, I think, 55 and over. We also, very interestingly, our demographics and the information that we've always had from IRIS, we see an older demographic than women self-referring into frontline services through the IRIS programme. When I say older, not that much older, sort of 35, 38 plus, many frontline services that have direct access for people referring in will tend to see more women in their late teens through to late 20s. So, you know, we do see an older demographic. And the oldest woman I ever worked with turned 81 when I was supporting her, and we are seeing quite a few women in 60s, 70s, and 80s. Oh, great, Joe! I can see you just said you just started working at the Women's Centre, and excellent.
There was also a question. I'm aware we're getting near the end, but there was also a question about how IRISi has pivoted around new ways of consulting, like through e-consult, or indeed work we have done, research work around remote consulting during COVID and beyond. Do you want to say something about that, Medina? This keeping up with the tech somehow in new ways.
Yeah. Just briefly, I can see Helen's letting us know that we're running out of time. Just a couple of minutes left. So yes, up until March 2020, every training and every trainer that we had done had been face-to-face. So within a month, when COVID struck and we were in lockdown, we completely pivoted. We put everything that was safe to do so online. We facilitated our 3-day face-to-face training being several sessions over more days, which we now still offer. We really do feel, though, that face-to-face training, especially when we're talking about this as an issue, and especially when we've talked about, you know, the people who we're training, many will be survivors themselves. It's really important that you have that face-to-face contact. But we do also work with e-consult and with some of the online patient access services to make sure that there are safe questions asked about violence and abuse. Jean. Oh, you're on mute, Jean.
I wasn't going to say anything more other than that we need to stop, unfortunately. We do have a couple more slides. So Helen, would it be possible to share those?
And can I suggest, could we perhaps copy and paste the questions, and then maybe we could do a Q&A sheet that we could send around to people? I'd be really happy to work on that.
Okay. So
Yeah. So yes, in Medina, I'll sort that out for you. Thank you both so much. That was really fascinating, and it is such an incredible story. The story of how IRIS has gone from, you know, the clinical trial right through to being a social enterprise that is continuing to work as an incredible partnership and innovate for the future. So thank you very much. I'm just putting up this final slide here for attendees. This is just different ways that you can keep in touch with us at the Centre for Academic Primary Care, and also IRISi. And yeah, as Medina said, we'll pull together the questions, we'll share the recording, we'll share the slides, and we will send you all of those via email. And just to point out also that we have got helpline information here should anybody feel that they need help and support. So I think that's it from all of us today. Unless Medina and Jean, there's anything else that you would like to say?
No, thank you for the great questions. Thanks, Helen.
Great. Thanks so much, everybody. And we hope to see you at a future CAPSI webinar. Thank you.